Hello friends, welcome to Medical Link. I am Dr. Prashant Gupta and today we are going to talk about diabetes. So it starts all from the pancreas. So pancreas has two parts, the endocrine part and the exocrine part. The endocrine part will secrete the hormone, whereas the exocrine part will secrete the enzymes. So the endocrine part will have islets of Langerhans. These islets of Langerhans are made up of group of cells which contains major cells and minor cells. The major cells are alpha cells, beta cells, delta cells and pancreatic polypeptide cells. So alpha cell contributes to 70% of islets of Langerhans, whereas beta cell contributes to 20%, delta cell will contribute to 5 to 10% of the total cell, and pancreatic polypeptide will contribute to only 1 to 2%. This alpha cell will produce glucagon hormone. This alpha cell will produce glucagon hormone, whereas beta cell will produce insulin hormone. Delta cell will secrete somatostatin hormone and pancreatic polypeptide will secrete pancreatic polypeptide. And there are minor cells as well. The minor cells are D1 cells and enterochromaffin cells. So D1 cells will produce BIP. BIP is vasoactive intestinal peptide. And enterochromaffin cells will secrete serotonin. So what is diabetes mellitus? Diabetes mellitus is a group of metabolic disorder which will share a common feature of hyperglycemia, that is increase in blood glucose, which may be due to insulin defect. So insulin defect can be either in action or in secretion. That is, insulin can be either non-functional or there may be absence of insulin. So if this is a blood vessel and this is a cell, so there are glucose present in the blood. So here beta cell will secrete insulin, whereas alpha cell will secrete glucagon. Now insulin will promote the uptake of glucose into the cell, where glucose is converted into glycogen and it is stored in the form of glycogen in the cell. So insulin will cause glucose to move inside the cell and will be stored in the form of glycogen, whereas glucagon will cause glycogenolysis and it will break the glycogen and convert it into glucose and it will move the glucose into the blood. Therefore, this insulin and glucagon will maintain the homeostasis of glucose between the blood and the cell. This is the regulation of glucose. So when there is decreased blood glucose, that is when the person is in fasting state, there is decrease in blood glucose level. So when there is decrease in blood glucose level, there will be decrease in insulin secretion and increase in glucagon level, which will decrease glycogen synthesis. So when insulin level is low, there will be decrease in glycogen synthesis, and because the glucagon level is high, there will be increase in glycogenolysis so that more glucose can be transferred to the blood. And this insulin will also facilitate hepatic gluconeogenesis. This insulin will also facilitate hepatic gluconeogenesis, by which the liver will form new glucose, and this will prevent hypoglycemia. And when there is increase in blood glucose level following a meal, there will be increased secretion of insulin and decreased secretion of glucagon, so that more glucose can be converted and stored in the cell in the form of glycogen. So there will be increase in glycogen synthesis and decrease in glycogen breakdown. So this insulin will also promote glucose uptake and utilization in the tissues. And skeletal muscle is the major insulin responsive site for postprandial glucose utilization, and this will prevent hyperglycemia. So during fasting stage, there is decrease in blood glucose. So this will result in low insulin and increased glucagon. So this will facilitate hepatic gluconeogenesis and glycogenolysis, while there will be decreased glycogen synthesis and thus preventing hypoglycemia. whereas when there is increased blood glucose following a meal, there will be increase in insulin secretion and decrease in glucagon secretion. So insulin will promote glucose uptake and utilization in the tissue. So skeletal muscle is the major insulin responsive site for postprandial glucose utilization and thus preventing hyperglycemia. So what happens in diabetes is there will be excess of blood glucose. So patient's body will have trouble moving the glucose from the blood to cells. So in diabetes mellitus, what happens is that there will be defective insulin either in their action or in their secretions. So it can either be non-functional insulin or it can be due to absence of insulin. So because of this, glucose cannot be converted and stored in the form of glycogen. So hyperglycemia occurring over a prolonged period of time, that is in chronic hyperglycemia, there may be secondary damage to multiple organ system and there will be decreased glucose in the cell. So cell will starve for energy despite having glucose in the blood. So despite of excess of glucose in the blood, cell will starve for energy because insulin is not sufficient to promote glucose uptake and utilization in the tissue. Therefore in diabetic patient there is excess of blood glucose. So patient's body will have trouble moving the glucose from blood to cell. So increase in glucose in blood will cause hyperglycemia. This can be due to defect in insulin secretion or due to defect in insulin action or both. So chronic hyperglycemia may cause secondary damage in multiple organ system and there will be decrease of glucose in the cell. This will cause cell to starve for energy despite having excess glucose in the blood. So from this we see that insulin has a major role in the causation of diabetes. So we'll talk more about insulin. Now we'll talk about insulin. So insulin is synthesized by beta islet cells of pancreas. In beta cell there are endoplasmic reticulum. In beta cells there are endoplasmic reticulum, and this endoplasmic reticulum, it is a storehouse of inactive form of insulin known as proinsulin, and this proinsulin is transferred to Golgi bodies where it is broken down into insulin and C peptides. So proinsulin is transferred to Golgi bodies where it is broken down into insulin and C peptides. So insulin is considered as anabolic hormone because it will activate GLUT4 receptor. So GLUT4 is glucose transporter 4 receptor, which is present on skeletal muscles and adipose tissue. So their main function is to increase glucose uptake into the tissue. So when there is increased glucose uptake into the tissue, there will be decrease in serum glucose level. So they will cause increased glycogen synthesis, increased lipid synthesis and increased protein synthesis. So this is why insulin is considered as anabolic hormone. These C peptides are marker of endogenous insulin secretion, and the C peptides is also used to differentiate between type 1 diabetes and type 2 diabetes mellitus. What happens in type 1 diabetes is, in type 1 diabetes there is beta cell destruction, therefore there will be decrease in C peptide level, whereas in type 2 diabetes mellitus beta cell is normal but the main pathology is in insulin resistance. So in type 2 diabetes mellitus beta cell is normal and there will be insulin resistance, therefore there will be normal C peptide level. So C peptide is a marker of endogenous insulin secretion, and it is also used to differentiate type 1 diabetes mellitus and type 2 diabetes mellitus, where in type 1 diabetes mellitus there is beta cell destruction, therefore there will be decrease in C peptide, wherein type 2 diabetes mellitus beta cell will be normal and there will be problem with insulin resistance, therefore C peptide will be normal. Now coming to insulin synthesis, insulin is formed as preproinsulin. Insulin is formed as preproinsulin. So it is a single chain 86 amino acid precursor polypeptide which contains alpha chain, C peptide, beta chain and signal sequence. This will be occurring in endoplasmic reticulum. Now subsequently what happens is that there will be proteolysis. This proteolysis will remove the amino terminal signal peptide. So proteolysis will remove the amino terminal signal peptide, forming proinsulin. So here there will be alpha chain, C peptide and beta chain, but there is removal of signal sequence. So there will be no signal sequence in proinsulin, which will be taking place in Golgi bodies. Now further cleavage of proinsulin gives rise to alpha chain, which is 21 amino acid, and beta chain of 30 amino acid of insulin. These are linked together by connecting segments called C peptides. Now both insulin and C peptides are then stored in secretory granules and secreted in equimolar quantities after physiological stimulation. Now coming to insulin release, glucose is the key regulator of insulin secretion from beta cell. So here what happens is, so when there is increase in glucose level, this will stimulate GLUT2 transporter and this will cause glucose to enter the beta cell. Now once the glucose enters into the cell, it is converted into glucose 6-phosphate with the help of enzyme glucokinase. So glucokinase will convert glucose into glucose 6-phosphate and during the process ATP is released. Now once the ATP is generated, this will cause inactivation of ATP sensitive potassium channel. So once the ATP sensitive potassium channel is inactivated, this will cause membrane depolarization. The depolarization of membrane will cause influx of calcium into the cell. So the influx of calcium will result in increase in intracellular calcium ion and this will stimulate the secretion of insulin. So what is happening here is, when there is increase in blood glucose level, this increased blood glucose level will stimulate the entry of glucose through GLUT2 transporter, and once the glucose enters into the cell, this is converted into glucose 6-phosphate with the help of enzyme glucokinase. During this process ATP will be released. This ATP will inactivate the ATP sensitive potassium channel, which will cause membrane depolarization. When there is membrane depolarization, this will cause influx of calcium into the cell. There will be increase in intracellular calcium. This will stimulate the secretion of insulin. Now we'll talk about insulin action. So insulin will cause adipose tissue. Insulin will stimulate adipose tissue and it will cause increased glucose uptake, increase lipogenesis and decrease lipolysis. Whereas insulin will stimulate the liver for decreased gluconeogenesis, increase in glycogen synthesis and increase in lipogenesis. Similarly, insulin will stimulate the muscles and will cause increase glucose uptake, increase glycogen synthesis and increase protein synthesis. Now we come to glycosylated hemoglobin, that is HbA1c. So this HbA1c is formed by non-enzymatic combination of glucose with globin of hemoglobin, and the clinical significance is to monitor glucose level for past 8 to 12 weeks, that is for 2 to 3 months, and it also helps in diagnosis of diabetes mellitus. So HbA1c will help in monitoring glucose level for the past 8 to 12 weeks and will help in diagnosis of diabetes mellitus. Now coming to interpretation, the normal value is less than 5.7%. In case of pre-diabetes mellitus, it is 5.7. It is in the range of 5.7 to 6.4%. To confirm the case of diabetes, there is more than or equal to 6.5%. And target HbA1c should be less than 7%. So this is the interpretation of HbA1c, where normal is 5.7, where normal is less than 5.7%. In pre-diabetic condition, it is 5.7 to 6.4%. In diabetic patient, it is more than or equal to 6.5%, and target HbA1c should be less than 7%. So what should be the normal plasma glucose level? So in normal condition, fasting blood sugar should be less than 100 milligram per deciliter. In 2 hours oral glucose tolerance test, blood glucose is less than 140 milligram per deciliter. HbA1c is less than 5.7%. So this is in case of normal individual. When you come to impaired glucose tolerance test is a pre-diabetic state where fasting blood sugar is in the range of 100 to 125 milligram per deciliter, whereas 2 hours OGTT is 140 to 199 milligram per deciliter, and HbA1c is in the range of 5.7 to 6.4%. So this is a pre-diabetic state or impaired glucose tolerance test. In diagnosis of diabetes mellitus, we have to look for clinical finding with signs and symptoms of polydipsia, polyuria and polyphagia, where there is increased tendency to drink water, there is increase in the frequency of micturition, and increased tendency to eat. So in case of diabetes, fasting blood sugar will be more than 126 milligram per deciliter. 2 hours of OGTT will be more than 200 milligram per deciliter. Random blood sugar is more than 200 milligram per deciliter, and HbA1c is more than or equal to 6.5%. So if you find this will confirm the diagnosis of diabetes mellitus. So what are the risk factors of diabetes mellitus? There are 10 important factors which you need to know. So there should be a family history of type 2 diabetes mellitus. It can be associated with obesity, habitual physical inactivation, that is sedentary lifestyle, race and ethnicity, that is black and Asian. If there is previous identification of impaired fasting blood sugar or impaired OGTT, if a patient gives history of gestational diabetes mellitus or delivering baby which is more than 4 kg of weight, hypertension, dyslipidemia where HDL is less than 35 milligram per deciliter, or triglyceride more than 250 milligram per deciliter, or polycystic ovarian disease and acanthosis nigrans, and if there is a history of vascular disease. So all these are the risk factors of diabetes mellitus. Now we'll talk about the classifications of diabetes mellitus. Now coming to the classification of diabetes mellitus, it can be classified into type 1 diabetes, type 2 diabetes, and type 1.5 diabetes or type 3 diabetes. This is a new entity which has been added. So type 1.5 diabetes, which is also known as type 3 diabetes, MODY, that is maturity onset diabetes of the young, which can be of different types: MODY 1, MODY 2, MODY 3, MODY 4, MODY 5, MODY 6, etc. And there is another group, that is maternally inherited diabetes with deafness, and this is due to mitochondrial DNA mutation. So diabetes mellitus can also be associated with pancreatic defect, which may be secondary to chronic pancreatitis, hemochromatosis, and cystic fibrosis. Diabetes mellitus can also be associated with other endocrinopathies like Cushing syndrome, growth hormone adenoma, hyperthyroidism, And diabetic mellitus can also be associated with different infections like viral infections like measles, mumps, Coxsackie virus and cytomegalovirus. It can also be associated with genetic syndromes like Down syndrome, Klinefelter syndrome, Turner syndrome and Prader-Willi syndrome. So these are classifications of diabetes mellitus. Now coming to type 1 diabetes mellitus. Type 1 diabetes mellitus is also known as juvenile onset diabetes mellitus or insulin dependent diabetes mellitus, that is IDDM. So type 1 diabetes mellitus usually occurs in children less than 20 years of age, and so it is called juvenile onset diabetes mellitus. So these children are thinly built, and type 1 diabetes mellitus is autosomal disorder which will result in beta cell destruction. When there is beta cell destruction, this will cause absolute deficiency of insulin. So patient will require insulin for survival. This is also known as insulin dependent diabetes mellitus. So type 1 diabetes mellitus is less common and it is seen only in 10% of the cases. Now coming to the pathogenesis, it is autosomal disorder. And there are various factors which are responsible for this condition, but the important factors are genetic factors and environmental factors. Where in genetic factors, where MHC gene and non-MHC gene are more commonly associated. So MHC gene is most commonly associated with MHC class 2 gene. So these are DR3 and DR4 and DQ8. This DQ8 has greatest inherited risk, whereas non-MHC gene is most commonly associated with PTP and 22 gene polymorphism and CTLA4 polymorphism. Now coming to environmental factor, viral infection plays a main role. So viral infections like measles, mumps, cytomegalovirus. So this virus will stimulate CD8 T cells. This viral infection will stimulate CD8 T cells which will cause destruction of the beta cell. So this process is done by molecular mimicry. Now coming to mechanism of type 1 diabetes mellitus. In type 1 diabetes mellitus, hyperglycemia and ketosis is seen only when there is more than 90% of beta cell damage. So hyperglycemia and ketosis is seen when there is more than 90% of beta cell damage. So what are the causes of beta cell damage? So beta cell damage is due to inflammation, and it can be due to autoantibodies formed against beta cell and insulin. So beta cell is damaged due to inflammation. So during inflammation, CD4 T cells will release cytokines. The cytokines are interferon gamma and tumor necrosis factor alpha. This will cause damage of beta cell, and this is indirect process, whereas CD8 T cells will cause direct destruction of beta cell. So beta cell damage can also be due to autoantibodies formed against beta cells and insulin. So in beta cell, antigen against which antibodies will be formed are glutamic acid decarboxylase antigens, which is the most common. So glutamic acid decarboxylase antigens are most common antigen responsible for beta cell damage. And also there is insulin cell autoantigen 512. So autoantibodies formed against beta cell and insulin are glutamic acid decarboxylase and insulin cell autoantigen 512. Now we'll talk about type 2 diabetes mellitus. In type 2 diabetes mellitus, it is most common type of diabetes mellitus. So type 2 diabetes mellitus is most common type of diabetes mellitus, and it is seen in more than 80% of cases. And it is not an autoimmune disease. It is not an autoimmune disease, and it is seen in elderly patient and obese patient. So it is seen in elderly patient and obese patient. So type 2 diabetes mellitus have multifactorial involvement, out of which genetic factor and environmental factor plays a major role. In genetic factor, there is polymorphism of TCF7L2 gene, that is, there is polymorphism of transcription factor 7 like 2 genes. Whereas in environmental factor, there is obesity, sedentary lifestyle, and dietary habits. In type 2 diabetes mellitus, initially there will be normal beta cells. In type 2 diabetes mellitus, initially there will be normal beta cells, and they will secrete insulin in response to hypoglycemia. So beta cell will secrete insulin in response to hypoglycemia. But the main problem here is insulin resistance. Insulin resistance is the basic pathology in type 2 diabetes mellitus. Now coming to metabolic defect in type 2 diabetes mellitus. So insulin resistance and beta cell dysfunction plays a main role in metabolic defect in type 2 diabetes mellitus. In insulin resistance, we'll talk about what is insulin resistance, what are the factors responsible for insulin resistance, and what are the mechanism of insulin resistance. So what is insulin resistance? Insulin resistance is decreased response of peripheral tissue to insulin. So there is decreased response of peripheral tissue to insulin. And the factors responsible for insulin resistance is central obesity. In fact, central obesity is the most important factor responsible for insulin resistance. Now what are the mechanism of insulin resistance? So number one mechanism is increased amount of free fatty acid associated with obesity. So in this condition there will be increased free fatty acid secretion, and this free fatty acid will go to the tissue like liver and muscles, and in tissues they will be converted to intracellular triglycerides. Now once they get converted into intracellular triglyceride, they undergo fatty acid oxidation. This fatty acid oxidation will cause formation of toxic substance like diacylglycerol and ceramides. So these toxic substances will inhibit insulin signaling, which will result in insulin resistance. Now second mechanism is due to adipokines. Under normal condition, adipose tissue will act as functional endocrine glands. So under normal condition, adipose tissue is considered as functional endocrine glands, where adipose tissue will secrete adipokines. So these adipokines are adipose tissue cytokines, which may be pro-hyperglycemic adipokines and anti-hyperglycemic adipokines. These pro-hyperglycemic adipokines are resistin and RBP4, that is retinol binding protein 4. This will cause increase in blood glucose. So pro-hyperglycemic adipokines will cause increase in blood glucose, and anti-hyperglycemic adipokines are leptin and adiponectin, which will cause decrease in blood glucose. But in obesity, what happens is that there is decrease in adipokines. When there is decrease in adipokines, this is the cause of insulin resistance. In obesity, there is decrease in adipokines. When there is decrease in adipokines, this will result in insulin resistance. Now third mechanism is due to inflammation. So here what happens, the free fatty acid within the macrophages and beta cells will stimulate inflammasomes. These inflammasomes will release interleukin 1 beta. This interleukin 1 beta is responsible for insulin resistance. Another mechanism is by peroxisome proliferated activator receptor gamma mutation, that is PPAR gamma mutation. So what is PPAR gamma? So PPAR gamma is a nuclear receptor. So PPAR gamma will activate adiponectin, and this will cause decrease in glucose level, and PPAR gamma will also cause free fatty acid deposition in adipose tissue. It will also cause free fatty acid deposition in adipose tissue, but not in liver and muscle. So when there is mutation in PPAR gamma, it will result in insulin resistance, and they are also associated with monogenic diabetes. Now another defect in metabolic disorder in type 2 diabetes mellitus is beta cell dysfunction. So increased amount of free fatty acid will result in damage to beta cell. Also amyloidosis, that is amyloid deposition, will also result in damage to beta cell. This amyloidosis is only seen in type 2 diabetes mellitus. Now another cause for beta cell dysfunction is abnormal incretin hormone in type 2 diabetes mellitus. Abnormal incretin hormone in type 2 diabetes mellitus. Normally what happens? Normally incretin hormone is secreted by intestine, and the main function of incretin hormone is to activate insulin hormone and inhibit glucagon hormone. Incretin hormone will activate insulin hormone and inhibit glucagon hormone in normal case, whereas in obese individual there is abnormal incretin hormone. There is abnormal incretin hormone which is responsible for beta cell dysfunction. Now coming to type 1.5 diabetes, it is a new entity which is also known as type 3 diabetes. Since they show few clinical symptoms of type 1 diabetes, they are also considered as variant of type 1 diabetes mellitus. As it has autoimmune origin, they are also known as LADA, LADA, that is latent autoimmune diabetes of adult. This type 3 diabetes mellitus, they are slow onset diabetes. They are slow onset diabetes and they require insulin for treatment. But the characteristic feature is that with controlled blood sugar, the risk of cardiovascular abnormalities are reduced. So if the blood sugar is controlled, then there will be decreased risk of cardiovascular abnormalities. Now we will talk about monogenic diabetes. Monogenic diabetes are uncommon diabetes. Monogenic diabetes are uncommon diabetes. And there are two main causes of monogenic diabetes. One is genetic defect in beta cell function and the other is defective insulin action. So in genetic defect in beta cell function, it is hereditary disorder and it is autosomal dominant. It is seen in younger patient less than 25 years of age, or it can also be seen in neonates. And genetic defect in beta cell function are not associated with beta cell abnormalities or beta cell autoantibodies, and they are also not associated with obesity. So examples are MODY, which is the most common form. MODY is maturity onset diabetes of the young. So this is the most common form. And the other group is maternally inherited diabetes and deafness, which is due to mitochondrial DNA mutation. And the other cause is defective insulin action, where there is mutation in gene regulating insulin receptors and insulin signaling. So here there is mutation in gene regulating insulin receptors and insulin signaling. And finally, we will be talking about complications of diabetes mellitus. So complications of diabetes mellitus can be acute complications and chronic complications. In acute complications, there may be features of polydipsia, polyphagia and polyuria. Second common acute complication is diabetic ketoacidosis, that is DKA. Diabetic ketoacidosis is most commonly associated with type 1 diabetes mellitus, where there is absolute deficiency of insulin. So in type 1 diabetes mellitus, there is absolute deficiency of insulin. So we know the function of insulin. We know that the function of insulin is to inhibit lipolysis and ketone body formation. So when there is absolute deficiency of insulin, there will be lipolysis and ketone body formation. So what is the mechanism causing diabetic ketoacidosis? Due to absolute deficiency of insulin, there will be hyperglycemia. This hyperglycemia has blood glucose of 250 to 600 mg per deciliter. This hyperglycemia will cause osmotic diuresis. This will result in dehydration and excessive thirst. Now, the absolute deficiency of insulin with increase in counter-regulatory hormones like growth hormones, catecholamines and ACTH hormones, they will cause release of free fatty acid from adipose tissue. So, deficiency of insulin and increase in counter-regulatory hormone will cause release of free fatty acid from the adipose tissue. This free fatty acid will go to the liver. In liver, there will be fatty acid oxidation, where there will be increased ketone body formation, and these ketone bodies are beta hydroxybutyrate and acetoacetate, which will result in metabolic acidosis. And finally, this will result in diabetic ketoacidosis, where there will be increase in blood sugar of 250 to 600 mg per deciliter. There will be formation of ketone bodies like beta hydroxybutyrate and acetoacetate, and there will be metabolic acidosis. So this is resulting in diabetic ketoacidosis. Now coming to the clinical presentation of diabetic ketoacidosis, patient will be thirsty, they will have nausea and vomiting, they may present with abdominal pain. So these are initial findings of diabetic ketoacidosis. In case of severe diabetic ketoacidosis, there will be labored breathing or gasping breathing, which is known as Kussmaul's respiration. So in Kussmaul's respiration, the patient will have labored breathing and gasping breathing. There will also be fruity breath odor, which will be due to acetone. Now coming to another acute complication, that is hyperosmolar hyperglycemic state. So hyperosmolar hyperglycemic state is most commonly associated with type 2 diabetes mellitus, where the main pathology is with insulin resistance. So there is small amount of insulin. Coming to pathogenesis, there will be small amount of insulin which will be inhibiting lipolysis, and there will be no ketone body formation. So decrease insulin and increase counter-regulatory hormone will result in hyperglycemia, where the blood glucose level is 600 to 1200 mg per deciliter, where blood glucose is 600 to 1200 mg per deciliter, and this high amount of blood glucose will cause severe osmotic diuresis. This will result in dehydration, coma and death. Therefore, mortality rate is higher in case of hyperosmolar hyperglycemic state more than diabetic ketoacidosis. So hyperosmolar hyperglycemic state is characterized by a triad of hyperglycemia, hyperosmolality, which is in the range of 330 to 380 milliosmoles per kg, and there will be dehydration without ketoacidosis. So there will be no ketoacidosis in case of hyperosmolar hyperglycemic state. Now coming to chronic complications, it can be due to non-enzymatic glycation of vascular basement membrane, and it can be due to osmotic damage. In non-enzymatic glycation of vascular basement membrane, it can lead to diabetic retinopathy, diabetic nephropathy, myocardial infarction, and neuropathy, where myocardial infarction is the most common cause of death in diabetes. In osmotic damage, glucose will be converted into sorbitol. This sorbitol will enter into the Schwann cells, and once it enters into the Schwann cells, it will cause peripheral neuropathy and cataract. So this was all about diabetes. I hope you have understood the topic. Thank you, and I will see you in the next video.